Well, welcome everyone to the January 14th, 2013 EKG Case of the Week. Before we get started, I just want to remind everybody about the upcoming fantastic conference in Las Vegas, the Resuscitation Conference. Check out the website at www.resus2013.com. Fantastic conference, lots of workshops and so on. One of the things that we'll be talking about is 12-lead EKGs, of course. And speaking of which, we had a great 12-lead sent to me just earlier this week by Dr. Abdullah Al-Zarani, and I sure hope I'm pronouncing that name properly. Abdullah is a PG3 resident, I think, at State University of New York, downstate. They have a big residency program, the SUNY downstate program. We've had a lot of our current residents come from that medical school. It's a great place. Abdullah and his attending saw a 64-year-old woman who presented to their emergency department complaining of a sore throat. Now, it turns out there's really no hidden information here. It's just a little unclear why the nurse or tech got a 12-lead EKG. Now, Abdullah's not really sure either, but nevertheless, we've all been in this scenario where you don't think you need an EKG, but now you're stuck with it. And sure enough, it's not a normal 12-lead. It's kind of a bizarre 12-lead EKG. The rhythm is really, as we say in medical parlance, messed up. Right? In fact, let's move forward to a rhythm strip. They got some really long rhythm strips, and we'll just focus on the lead 2 rhythm strip, and I'll blow this up for you. So this whole thing is lead 2, where the P waves are pretty clear. What you notice is that there's a run of what looks like sinus rhythm, 4 nice beats, PRs are pretty good. But then, just before and also afterwards, and for most of the strip actually, you've got a different morphology QRS complex, and you've also got P waves that are too short, so close to the QRS complex they can't possibly be conducted. There's no PR there. Then the P waves start showing up after the QRS complexes. What in the heck is going on here? What is this rhythm? Well, that's what we're going to focus on. We're just going to talk rhythms in this session today. Otherwise, it's going to be way too long. And in fact, we're going to focus on some concepts pertaining to AV dissociation and complete heart block. There's a couple of things that you need to understand before we go back to Abdullah's 12-lead EKG and realize how simple it can be. So this is what I'm going to start with. This is a clear-cut, no-brainer piece of cake, AV dissociation and complete heart block. Anybody with decent experience reading EKGs will pick this up immediately. Don't worry about the bundle branch block. We're just focusing on the rhythm here. When you look at that rhythm down there in lead 2, you see P waves that march out very nicely. Some of them are buried in the QRS complexes. No big deal. And they just, I'm kind of messing up the drawing, but you get the point. The P waves are occurring very, very regularly. The QRS complexes are also very regular, and they're narrow, so it's not a ventricular type of rhythm. It's probably a junctional rhythm. And so that means it's AV dissociation. The atrium's doing its own thing. The ventricle is doing its own thing. And they're working fairly independently. That's AV dissociation. Now, what makes it also complete heart block is that none of the P waves are getting conducted. How do you know that? Well, the reason that you know that is that the QRS complexes are completely regular, number one, and the PR intervals are constantly changing. You know, there's a long one and then a short one and then a little retrograde one. And so there's no talking between the atrium and the ventricle. All right, so here's your heart. And many of you know I'm really bad at drawing, but I was pretty bad in anatomy also. So I think this is what the heart looks like, and it probably doesn't, but whatever. Here's your atrium up here. Here's your ventricle. And so AV dissociation means that the atrium is beating regularly and the ventricle is beating regularly. Actually, we can make them narrow if it's coming from the AV node, all right? And complete heart block means that there's a wall between the two, so none of these atrial beats are actually making it to the ventricle to set off the ventricle, okay? That's what AV dissociation with complete heart block means. Now, let me ask you this. Supposing the atrium was beating at a rate of, arbitrarily, I'll just say 80. And supposing the ventricle was beating at a rate of around 80, say 77, okay? So they're beating very closely to each other in terms of the rate. But there's AV dissociation. Is that possible? Sure, it's possible. It's possible for the atrium and ventricle to be independently working, but at a very similar rate. And when that happens, what you end up seeing is a rhythm, and we're going to look at lead V1 here. What you end up seeing is a rhythm where there's P waves, all right? Let me mark out these P waves, all right? Okay, so they're mapping out very regular, and if you had calipers, you keep marching them out. There's a P wave right at the beginning of that QRS complex, and it keeps going, and then there's one, let's see if I can get rid of that. There's a P wave right up there also, okay? So the P waves are occurring very, very regularly, and the QRS complexes are occurring regularly. They're narrow, so it's probably a junctional escape rhythm. And the PR intervals are changing. So that means that this is AV dissociation. There's, that PR looks okay, and that's a little bit longer. If you map it out, that's a little bit longer there. That's a short PR. So going this way, the PR intervals are not staying the same, so it's not Mobus 2. The PR intervals are not getting longer with the dropped beat, so it's not Mobus 1. But nevertheless, the PR intervals are changing. So if you have PR intervals that are changing, but it's not Mobus 1 or Mobus 2, it's got to be complete heart block. All right? So this, and also you'll notice that the P waves in the QRS complexes are very similar in rate. When you see P waves in QRS complexes that are similar in rate, they use the term isorhythmic AV dissociation. That means the atrium and the ventricle are in an isorhythm, I guess. The rate, the rhythm is fairly similar. And Marriott and some other authors have said that when you have this isorhythmic AV dissociation, the P waves they get close and then they disappear because they get buried in the QRS and then they show up again. And he referred to this term as the P and the QRS complexes are flirtatious, or they're dancing. That's not my term, that's their term, published in the literature. And so don't be confused by this, though. When you see P waves and QRS complexes that are close together, but the PR is changing, and it's not Mobus 1 or Mobus 2, that's simply isorhythmic AV dissociation. And in this case, there's complete heart block. How do you know there's complete heart block? None of those P waves are being conducted. The QRS complexes are occurring very, very regularly. All right? Now, some of you may be saying, why is he saying AV dissociation with complete heart block? All right? I've said that on 2 consecutive cases. Some of you might be thinking, I thought AV dissociation and complete heart block were synonymous. Why is he being redundant and saying AV dissociation and complete heart block? Well, AV dissociation and complete heart block are not the same thing. AV dissociation simply means that the atrium is beating regularly and the ventricle is beating regularly. That's all that AV dissociation means. Complete heart block means that there's a wall between the two and nothing is getting through. However, if you have a scenario of AV dissociation where every now and then a P wave does slip through, producing an early QRS complex, essentially in that case what you have is AV dissociation without complete heart block, also referred to as AV dissociation with incomplete heart block. And that's kind of an important thing to understand, that AV dissociation is not synonymous with complete heart block. This EKG is a nice example. All right? If you look carefully, what you notice is there are QRS complexes right in the middle. There's 3 of them that are all about the same size, and that's about the same size also. But you've got different morphology. There's a different morphology also. There's 2 QRS complexes that are a little bit smaller than the other ones. Furthermore, you'll notice that with those 2 QRS complexes that are a little bit smaller, the PR intervals are pretty reasonable. Those are pretty normal looking PRs. The other QRS complex, those PRs are they're just not going to be conducted. But these are conducted. And then the one other thing that you'll notice, again, you've got atrial beats that are mapping out very nicely and normally. And here you've got QRS complex. Let me see if I can get that right. QRS complexes that are very nice and mapping out normally. But if you continue, that one came early, right? That came early. And that's your clue that this P wave must have been conducted to the ventricle. What makes you think that P wave got conducted to the ventricle? Because this QRS came early. It's associated with a normal looking PR, and the morphology is different than the other morphologies. So when you see the QRS complex change morphology, it's got a normal PR and it comes early in the cycle, that means that the P wave actually did get conducted through the ventricle. So this is an example of AV dissociation. In other words, the atrium is doing its own thing, the ventricle is doing its own thing, but every now and then an atrial beat does get conducted, and therefore this is not complete heart block. All right? So let me show you another example, and you'll notice a few different morphologies. Again, there's one type of morphology of QRS, and you'll notice that the PR intervals there are not possibly being conducted. And then there's another morphology for QRS, which comes a little bit early in the cycle, and there's a normal PR with those, and the morphologies change. So if this is the intrinsic rate, you'll notice that this came early. Okay, let me show you another example. There's a couple of different morphologies. There's this morphology, and then there's also this morphology. So there's a couple of different QRS complex types in there. You've also got an atrium that's doing its own things, mapping out very regularly. I'm screwing up again, screwing that up, but the atrium is beating very regularly all the way across, and so on. You've also got a ventricle that appears to be marching out, but then you've got a different appearing beat that comes early in the cycle. The QRS morphology is different, and that PR interval looks very normal. That's your hint that this, excuse me, this is AV dissociation, but without complete heart block. It's always better to have incomplete heart block compared to complete heart block, wouldn't you say? Okay, so now there are two things that we've talked about. We've talked about something which may be new things to you. We've talked about the concept of isorhythmic AV dissociation, which is when the atrium and ventricle are beating independently, but the rates are very similar. And we've also talked about the concept that AV dissociation can occur without complete heart block. Now, let's go back to Abdullah's EKG. And let's take a look at what the atrium's doing first of all. In fact, why don't we just move forward to the rhythm strip here. All right, let's take a look at what the atrium's doing. You've got your atrial beats, which some of them are buried, okay? And the atrial beats map out very nicely. If you pull calipers out, you'll see these atrial beats map out perfectly. You'll also see that we're going to separate the 12 lead there. The ventricle is beating very nicely, okay, which happens to be the same rate there. But if you continue on, you'll notice that when the morphology changes, it comes a little bit early. And so these beats have a different morphology. They also have a normal PR, and it also came a little bit early. So what is going on here? Well, number one, the atrium and ventricle have their own thing going on. That means, first of all, that there's AV dissociation. Second point, the atrium and ventricle are very, very nearly the same rate. Those P waves are flirting with the QRS complexes. They're dancing with the QRS. They're getting close. They're getting further. You know, they're doing a little samba, I guess. I don't know. That's kind of corny, but whatever. So this is an example of isorhythmic AV dissociation, and the QRS complexes are different in a little run right there, associated with the normal PR, and it came just a little bit early in the cycle. What does that mean? This means that there is not complete heart block. In other words, this is incomplete heart block. That means that complicated looking rhythm that we saw earlier is actually, once you break it down and you understand a couple of these simple concepts, is very simple. This is isorhythmic AV dissociation with incomplete heart block, or without complete heart block. Now, why do you need to know about this? Well, first of all, you just need to know about EKGs. When you look at this rhythm, you don't want to say, oh my gosh, I have no idea what's going on. Let me call cardiology so that they'll think I'm dumb. So you've got to know how to read rhythms, number one. Number two, you have to understand that AV dissociation and complete heart block are not the same thing. Complete heart block is clearly worse than incomplete heart block. Number three, you have to understand the concept of isorhythmic AV dissociation, because if you didn't know something like that exists, then you're going to get confused in rhythms like this, where the QRS and the P waves are close but not exactly mapping out. And then in terms of clinical relevance of this, well, isorhythmic AV dissociation and AV dissociation without complete heart block can be a normal variant, believe it or not. Highly conditioned athletes, probably not this 64-year-old woman, but highly conditioned athletes can live with this. And as long as the ventricular response is pretty good, they're hemodynamically stable, they don't have any other concerns, patients can live with this. This person can be followed up as an outpatient, and probably, very possibly, nothing needs to be done if she hasn't been having any symptoms at all. It can be a normal variant. And if there is any hemodynamic instability, then you're going to treat it like a complete heart block or like AV dissociation. But in and of itself, this rhythm is relatively common, or certainly not uncommon, and it can be completely benign. So that's an important thing you need to understand when bizarre-looking things can be benign as well. All right, so treat the patient with this particular rhythm. You don't need to worry too much about the rhythm unless they're hemodynamically unstable. So anyway, somewhat complicated rhythm, which is actually very simple once you understand that something called isorhythmic AV dissociation exists, and once you understand that AV dissociation is not always associated with complete heart block. All right, so hopefully that was helpful. Next week we'll go back to maybe something a little bit more simple, but I really appreciate Abdullah sending this 12-lead EKG, and I hope you all benefited from our walk through that rhythm. Thanks a lot.